Assalamu alaikum, everyone. Am I audible?
Walaikum salam, yes.
Okay, so let's begin. I tried my best to cover both the pituitary adenomas and the endonasal transsphenoidal approach in the same session, but apparently it's not possible, at least in 60 minutes, because 60 minutes are, I realized that they are insufficient to even completely cover pituitary adenoma. I did have to purposefully leave some medical management out. So let's see where we get to towards the end of this session. And then maybe we will continue tomorrow with the endonasal transsphenoidal approach and a few of other subtopics. So without further ado, let's proceed. Before we move on to the pituitary tumors, we need to know the basic embryology and how the pituitary tumor develops, pituitary gland develops. So I am very sure that you all of you know that this here is the neuroectoderm and this here is the normal ectoderm. This is the rat case pouch, which is an outpouching, whereas this is the neuroectodermal outpouching, which is from the diencephalon. So this ends up making, if you see, and if you follow the colors, this ends up making the neurohypophysis, which is the posterior pituitary, right? Whereas the rat case pouch ends up making the anterior pituitary, which is adenohypophysis. Let's move on to the next slide. It will more clearly tell. Now, I am going to tell you the parts of rat case pouch that it leads to. It makes pars tuberalis, it makes a pars intermedia, and a pars distalis. Pars tuberalis ends up becoming the part of the infundibulum. Please mute yourself, whoever this is. It's very, very disruptive. Okay, coming back. If we see the stalk, this is pituitary stalk. You can see that part of the pituitary stalk or the infundibulum is made by the neuroectoderm, which is an outpouching from here. This here is the diencephalon. This is the optic chiasm. Here is the third ventricle. And here we have the lamina terminalis. So this is a diencephalon outpouching that makes part of the pituitary stalk. Rest of the part is made with the help of pars tuberalis. And pars intermedia is something that is vestigial in humans. It does not end up forming any significant structure, whereas pars distalis forms the anterior pituitary that we all know of. Hence, the tumors that we discuss, usually when we discuss pituitary adenomas, we automatically mean that they are the tumors of anterior pituitary, because the tumors for posterior pituitary are completely different. Let me clear this. Without wasting too much time on the embryology, we are going to move to the pituitary adenomas, which are now called pituitary neuroendocrine tumors in the new WHO classification. The easiest one, you classify them based on the size. Microadenomas are less than 10 mm. Macroadenomas are more than 10 mm. If they are more than 40 mm, then they are giant adenomas. Then we have function-based classification, pretty easy. We have functioning adenomas that are secretory. They secrete biochemical substances that end up disrupting the body's normal homeostasis. Then we have the non-functioning adenomas, which do not do much in terms of secretion. How do they affect us? They affect via mass effect. So mass effect is more of a problem in non-functioning adenomas. They need to go beyond a certain size to cause any symptom in the patient. Whereas for functioning adenomas, size is less of a factor. Even a microadenoma that is functioning can be potentially disruptive for a patient's life. But if it is a macroadenoma and a functioning adenoma as well, then it ends up being a double-edged sword, because now the patient is going to have biochemical disruption along with the mass effect. This is the easy part. We hop on to the grading first, Knosp grading and Hardy grading. Why? Because they tell us how much the pituitary tumors have invaded the surrounding structures. How much is the invasion? How much is the involvement of all the surrounding structures? So let me draw here. We have pituitary in the center. We have the cavernous sinuses here. And what are the structures in the cavernous sinus? Can somebody unmute themselves and let me know? Anybody?
3, 4, 6, V1 and V2.
Okay, where is 3, 4, 6?
In the upper part of the sinus.
Okay. Where is V1? Where is V2?
In the lower part of the sinus.
The 3,
This
4,
is the
6
carotid.
wall of the cavernous sinus.
Where is 3, 4, 6?
The third, fourth, and V1, V2 division is on the lateral wall, and
Okay.
the sixth nerve is on medial, just beside the ICA.
Okay, who is this?
I'm Dr. Rohan from. I'm a neurosurgery PG from Madurai, India.
Oh, welcome to the neurosurgical case room. I'm very happy that you are here with us. I guess you're a newer attendee, so I was not familiar with the voice. Thank you so much. You're right. Why
Yeah.
is this important for us? Why is this important? Understanding where the nerves and the artery lie within the cavernous sinus, it's really, really important if you want to understand the grading, right? Let me change this slide. So, do you see this now? You can see that this here is the lateral wall. This here is the substance. And inside the substance, we can see that there is ICA. And there are some lines. What are these lines? Are they visible? I think they are. Let me highlight them with a nicer color. So what are these lines? They're labeled. Anybody can unmute and name them.
Median, medial, and lateral lines.
Okay, first of all, what is this section?
Coronal section.
This is coronal section, right? We are looking at a single-sided view. This is a coronal section. If we had a complete view, this would have been the pituitary adenoma. This would have been the cavernous sinus continuation on the opposite side, right? So this is a coronal section. It's easier to orient if you know what section is this. This here is the pituitary adenoma. What are these lines here? This is the medial tangent, okay? The medial tangent denotes where the ICA starts. Then we have the intercarotid line. There is another name for intercarotid line. What is that called?
Median.
That's right. That's the median line or the midline. That line denotes half of the internal carotid artery. And then we have the lateral tangent line. Afterwards, we have this here is the wall of the cavernous sinus, right? Are you all with me till here?
Yes.
What ends up happening is when we talk about Knosp grading, I'm going to change the color. When we talk about Knosp grading, we are assuming that any lesion which is medial to this line. What line is this? The green line? It's medial tangent line, right? The green line is the medial tangent line. So any lesion that is medial to this is what grade?
0.
Grade 0. Okay. When this line is crossed, let me draw the second line. This red line is the median line or the intercarotid line. Okay.
रोटी बस
And
9 बजे बना देना 2 रोटी
please mute yourself. Who is this? Everybody, please mute yourself. This is highly disruptive. Okay, coming back, any lesion which crosses the first line here, which is the medial tangent line, but stays medial to the intercarotid line or the median line, what grade would this be? It's going to be
One.
grade 1, right?
Grade 1.
Yes, that's right. There's a cheat code here, and there's a cheat code here for all the questions that I'm asking. So if this lesion is going to encroach on the ICA, but it is going to stay medial to the median line or the intercarotid line, then it is going to be grade 1 in the Knosp grading. Okay? Assuming that this lesion, let me redraw this, that this lesion ends up growing even more and it crosses the median line. It goes beyond the median line, but it still stays medial to the lateral tangent line. Now, what grade would this be?
Grade 2.
That's grade 2. So when we talk about Knosp grading and we are saying that it's grade 2, this means that the lateral tangent line has been reached, but there is no complete encasement of ICA as of yet. When I say that it's grade 3, what would that mean? That the lesion has either involved the superior compartment of the cavernous sinus or it has involved the inferior compartment of the cavernous sinus, right? This still means that there is some portion that is free. This portion of ICA wall is still free. So there is no complete encasement. Are you all with me?
Yes.
Grade 0 is medial to the medial tangent line. Grade 1 is medial to the intercarotid line. Grade 2 is medial to the lateral tangent line. When we talk about grade 3, there is involvement of cavernous sinus. If it is the superior component of the cavernous sinus, then it is 3A. If it is the inferior component of the cavernous sinus, then it is 3B. Okay? What do I mean when I say that it's grade 4 Knosp?
When both inferior and superior are involved or engulfing the carotid artery.
Yes, and there is complete encasement of the ICA. That is grade 4. When we say grade 4, this automatically means that the resection is not going to be possible since ICA is a non-sacrificable structure. Are we clear till here?
Yes, ma'am.
Okay, so grade 0 is medial to the medial tangent line. Grade 1 is medial to the intercarotid line. Grade 2 is medial to the lateral tangent line. Grade 3 is cavernous sinus. If it is superior, it's 3A. If it is inferior, it's 3B. Grade 4 means there's complete encasement of ICA. Now let's see it in another image. What grade is this? Grade 0. Where will be the lines be here? Let me draw them. Which line is this yellow line? Roughly.
Median line.
This is the median line or the intercarotid line. Then we have this orange line. Okay, what is this line?
Medial.
Medial tangent line. Which would be this line? The green line.
The lateral.
Lateral. So where is grade 0? Grade 0, the lesion is medial to the medial tangent line, right? Then you see the grade 1. Where is it? It has crossed the medial tangent line, but it is still medial to the median line or the intercarotid line, right? Then we have grade 2. For grade 2, it is still medial to the lateral tangent line. You can see that this here, the white line here is the lateral tangent line. That is grade 2. Then we have grade 3. For grade 3, you can see that there is involvement of the superior portion of cavernous sinus. So this is going to be 3A. Here you see that there is involvement of the inferior portion of the cavernous sinus. So this is 3B. And this here is the self-explanatory grade. It's grade 4 because there is complete encasement of ICA. Are we clear till this?
Yes.
Okay. Which grading is this?
Hardy's.
Hardy's, right? So what do we see in Hardy's? We see the extension and we see how the cella is behaving. One is a stage and one is grade. Stage is the extension or the involvement of surrounding structures. It might be slightly difficult to understand on this text-only slide, but I have an image where I'm going to show the systems, and it would be slightly easier in order to understand. So stage 0 is the lesion is confined to sella. There is no suprasellar extension. Let's move to the next slide. You can see that this is sella here. Okay. This here is sella. This is pituitary, assuming that there is a lesion here. Okay. If a lesion is confined only till here, what grade would that be?
0.
0.
0.
Sorry, I meant stage. That would be 0. There will be no suprasellar extension. Then we have A. A would mean there is no there is extension to the suprasellar cistern only, but the third ventricle recess is still preserved. So this here is the suprasellar cistern. It's going to slightly go out of the sella. The lesion is going to extend only till here. It's not yet going to involve the third ventricle. What is stage B? Recess of the third ventricle obliterated. C is third ventricle grossly displaced. D is intracranial. Now let me try drawing it here. This here is the recess of the third ventricle. If a lesion ends up growing big enough that it's compressing the third ventricle slightly posteriorly, then what it would be? Which grade it would be?
B.
Okay. And if it goes even further, okay, and it completely grossly displaces the third ventricle, then what grade it would be?
C.
C. And when the tumor goes completely inside, then it is intracranial. Understandable? If it ends up involving the periphery is the cavernous sinus, right? We see this picture here. Just give me a minute. Okay, if you see the periphery here of the pituitary gland, you see that any extension in the lateral regions is going to involve the cavernous sinus, right? So what ends up happening is, if there is no suprasellar extension, then it's stage 0. If there is extension to the suprasellar cistern, then it is stage A. If there is recess of third ventricle, if that is obliterated, a recess would be here. If that is obliterated, it's going to be B. If this is displaced, I have an image in the radiology where the third ventricle is grossly displaced, then it is going to be grade C. And intracranial is grade D. Any lateral extension is going to grade it very highly because cavernous sinus extension makes pituitary tumors relatively unresectable. They are not amenable to complete resection anymore. So any lateral extension is going to label it as E. Okay. Grades. Grades would show if the cell is normal, the tumor size is less than 10 mm, then the grade is 1, straightforward. If the cell is enlarged, which means that the tumor is bigger than 1 centimeter, then it is grade 2. If there's local perforation of cellar floor, then it's grade 3. And if there's diffuse cellar floor erosion, if there's diffuse restriction, then it is grade 4. Let me draw. If there's a perforation, then it's grade 3. If there is complete erosion of the cella, then it's grade 4. Are you all with me till here?
Yes.
Why do I feel that you all are slightly lost? It's boring and it's dry and it's difficult, I know, but bear with me. I don't need to go over the Knosp or the Hardy classification, right?
Ma'am, for paracellular masses, can we apply Hardy stage for strict paracellular masses?
For strict paracellular masses, no, I'm not aware. As far as I'm aware, Hardy is for pituitary adenomas and the lateral extensions of pituitary adenomas.
Okay, thank you.
Okay. So we are back to functioning adenomas. And what are the most common functioning adenomas? Prolactinomas, obviously. They are the most common secretory tumors. What happens when there is excessive prolactin? It suppresses the hypothalamic pituitary gonadal axis. We say it HPA axis. So in females, there's going to be amenorrhea, there's going to be galacturia, and there's going to be infertility. In males, there's going to be decreased libido, there's going to be erectile dysfunction, occasionally, very occasionally, gynecomastia. Gynecomastia is not a primary feature in the usual male patients with pituitary adenoma. So how is the patient going to present in your clinic? She's usually going to be a young female. Oftentimes they are married and they have been trying to conceive for a long amount of time, but there is subfertility, and they might also report that their cycle is disturbed. Galacturia is not something that I have seen very frequently in our own clinical practice. I'm not aware about the other institutes, but subfertility and amenorrhea or oligomenorrhea is a very common presentation. Regarding males, they might have decreased libido and sexual dysfunction, occasionally gynecomastia. So prolactinomas are the only pituitary adenomas in whom primary management is medical. You give them a trial of medical management and you only move towards the surgical tier once that medical management fails. Either the patient is not responsive, or the side effects are unbearable, or there is mass effect, or any other emergency like a pituitary apoplexy where vision is threatened. Only in those situations you are going to treat a prolactinoma surgically, or if a patient wishes because they want to complete the family and they don't want to undergo a very long medical treatment, then surgical treatment is an option. Otherwise, prolactinomas are manageable medically. So what ends up happening is when there is excess prolactin, it ends up inhibiting the GnRH. When the GnRH is inhibited, then the LH and FSH are also decreased in terms of secretion. This leads to a generalized state of hypogonadism. If there is long-term exposure to high prolactin levels, what ends up happening is we see a presentation similar to women in menopause, right? Because what happens in menopause, women do not have enough estrogen, so they end up having estrogen-deprived osteoporosis or osteopenia. It's the same thing that happens to patients with prolactinoma. They end up getting osteoporosis or osteopenia because these hormones are critical for maintaining bone mineral density. Are you all with me till here?
Yes.
Yes, ma'am.
Okay, so these are some normal levels. Non-pregnant females are less than 25. You really need to remember this if you are preparing for any exam in the coming few weeks or so. For non-pregnant females, the normal range is less than 25. For males, it's less than 20. For pregnant females, 80 to 400 nanograms per ml is okay. More than 200 is suggestive of prolactinoma. If it goes above 400, then it is definitively diagnostic for prolactinoma. Less than 100, between 25 and 100, it is either stock effect or there are other causes like some drugs, cimetidine, etc., that might be mimicking the effect of prolactin. There are two very important diagnostic pitfalls. I am sure you are all aware of them. There's something called hook effect and there's something called stock effect. One is a false positive and one is a false negative. What ends up happening in hook effect is it's a false negative state. Why false negative? Because there is a prolactin adenoma which is secreting such high levels of prolactin that when the lab technician is testing, the sample ends up saturating the lab antibodies and there's a false low reading. So this is a false negative situation. Okay, and what is the result going to be? The result is that you see a huge tumor. On the MRI, you see clinical presentation of prolactinoma, but the levels are normal or mildly high, which is not correlating with the clinical and the radiological picture. So what do you ask the lab technician to do? You ask them to dilute the blood sample and then retest it. Am I clear?
Yes, ma'am.
Madam, please
Yes.
repeat this point. Please repeat
Okay.
this point.
So hook effect is a false negative. Let me write this so that you end up remembering. I am going very slow today, deliberately very slow, because I realize that a lot of people are not 100% clear about the differences. Hook effect is a false negative situation where there is a problem, but it is not apparent on the lab test. What ends up happening is you have a patient in your clinic with classic picture of prolactinoma. Patient has amenorrhea, patient has subfertility, and you get an MRI, there is a pituitary adenoma, you are suspecting a prolactinoma, right? Then you send a lab sample for the prolactin, and the lab sample comes back either normal or the prolactin is slightly elevated, which is not diagnostic, right? What ended up happening was, since it was a huge tumor, huge prolactinoma, the levels were so high that when the lab technician tested that sample, the lab antibodies saturated and the result came as falsely low. It was a false negative result. So what you ask the lab technician to do, you are going to ask them to rerun that sample or another sample after dilution. I think the dilution is 1:1000 titers. I don't exactly remember. So please spare me if I don't, but I think it's 1:1000 titers. So you ask them to dilute the sample and then rerun the test. And when they rerun the test, then the test is often positive for raised prolactin. So this is a false negative situation. Are we clear now?
Yes, ma'am. Thank you. Thank you.
Okay, so now we have stock effect. Stock effect is pseudoprolactinemia. There is no problem, but it ends up mimicking as the problem. So what is the situation going to be? It's going to be a false positive situation. Okay? When does it happen? There is a non-functioning tumor, okay, and it is compressing the pituitary stalk. What ends up happening is this pituitary stalk is the runway for the dopamine, okay? This thing helps dopamine reach here. So what ends up happening is, and please remember that dopamine is the prolactin inhibitory factor, right? So what it does is, it stops the secretion for prolactin. What ends up happening is, if there is a lesion and it is compressing the stalk or the infundibulum, then the dopamine cannot reach the pituitary, okay? Which means that the inhibitory factor is unable to reach where it was supposed to reach. What that means is that the prolactin can get secreted unstopped. Am I clear?
Yes, ma'am.
Yes, ma'am.
Yes.
Okay.
Yes, ma'am.
So
Yes,
stock
ma'am.
effect is, it's a false positive effect. Patient might have a pituitary tumor, but it might not be a prolactinoma. So what ends up happening is, because of the compression of the stalk, there is a stalk effect. There is pseudo high levels of prolactin. And usually they are most often under 100, or in certain situations, sometimes between 100 to 200. They never go above it. So when we talk about medical management for prolactinomas, there are two options. We treat them with dopamine agonist. We have two options with dopamine agonist. We have cabergoline and bromocriptine. Bromocriptine is the traditional option. It's the cheaper option. Cabergoline is the newer and the preferred first line option now, unless cost is a major issue, because cabergoline cost can go up to it can go anywhere between 4,000 to 7,000 US dollars for a year. So it's really expensive, even for patients in developed countries. But it is still the first line treatment. Why? Because the side effects are much lower compared to the bromocriptine, and the tolerability for the patient is higher. The shrinking of the tumor, which is the remission of the tumor, that is a lot higher. It goes up to 90%. It has a long half-life, so you only have to dose for once or twice a week. And there is a very lower side effect profile, especially the nausea and the vomiting that is highly associated with bromocriptine and is often the reason for discontinuation of bromocriptine. Interestingly, the serious side effects that cabergoline has, they are much more serious than whatever bromocriptine has. But bromocriptine is really, really difficult to tolerate because it induces severe nausea and vomiting. So the patients often end up discontinuing it. Let me move. The starting dose is 0.25 mg twice weekly. Please remember this if you're an exam candidate. In the current guidelines, you need to dose them twice weekly. There are physicians who might prefer a once weekly dose for which you need to go up to 0.5 mg. Okay, then you get the patient retested after 4 weeks. If the dose is increased by 0.25, if the prolactin remains elevated, then you need to increase the dose by 0.25 to 0.5 mg until the target level is reached. Am I clear?
Yes, ma'am.
Okay. So the maintenance dose is usually 1 mg per week. Some may require higher doses, but higher doses have a catch or certain pitfalls. We are going to see which. There are some serious long-term effects. One of them is impulse control disorders. Patient might have compulsive behavior, compulsive gambling, compulsive lying, hypersexuality. There might be binge eating, and this is way more common with cabergoline, and especially if you go anywhere above 2 mg. If you stay till 1 to 2 mg maintenance dose per week, then these side effects are less likely. They can still happen depending on the sensitivity of the patient, but less likely. Why? Because these are dopamine agonists. So they fire up the brain's reward centers. And when the brain's reward center is fired up, it wants to do everything impulsive, like gambling, like binge eating, like hypersexuality, etc., etc. So there is cardiac valvulopathy, which is also rare at the dose that we use for pituitary adenomas. There are going to be psychiatric symptoms, rare cases of hallucinations, paranoia, and usually cabergoline is avoided, or these patients are strictly monitored if there is prior history of psychiatric illness. Mental health workup is a formal workup done in patients on cabergoline in developed countries. When we talk about bromocriptine, all the serious side effects that come with cabergoline, they are not as prominent with bromocriptine. But the problem is that the tolerability is really difficult. Hence, patients end up discontinuing it. Also, the tumor remission rate, the shrinking rate of the tumor is lower with the bromocriptine. So we only reserve them for patients where cost is a major issue. And sometimes physicians prefer them in pregnancy, not because cabergoline is not safe. Please hear me out on this. Bromocriptine is still occasionally preferred in pregnancy because there is more data since it's an older drug. Cabergoline has been increasingly used now without much significant side effects, and it is generally considered safe. But since the data is not enough, since it's a relatively newer drug, a lot of physicians still use bromocriptine as a first line. Am I clear?
Yes.
Okay, so the starting dose is 1.25 mg, and we advise the patient to take it with some food or a snack, and then the maintenance is typically 2.5 mg 2 to 3 times daily. Now remember that the dose compliance is also going to be an issue with the bromocriptine because it's BD to TID every day, whereas the cabergoline was a once weekly or twice weekly thing. Side effects include severe nausea and vomiting. I think I have elaborated that enough. Yes, there's orthostatic hypotension. Patient is going to tell you that when I get up after standing or lying down for a long period of time, then I get dizzy. I often fall down. That is orthostatic hypotension. So when we put patients on bromocriptine, we tell them two things. We tell them that when they take the drug, they have to take it with a food, with anything to eat, so that there is lesser level of nausea. And we also counsel them regarding orthostatic hypotension that when they have been lying down, they have to get up slowly. They cannot, stand back on their feet quickly. Nasal congestion is a problem. Vasospasm in the digits, which is very similar to Raynaud's phenomenon, that is also a problem. Patient dropout rate is very high. So I think I have already done this. because we do not have significant data for the cabergoline, a lot of physicians still use bromocriptine as the first choice. So this is a comparison in terms of the efficacy of both the drugs. In terms of prolactin normalization, tumor shrinkage, complete tumor disappearance, you will see that cabergoline is much, much more superior. PRL levels were normalized up to 85 to 95% with patients on cabergoline, whereas bromocriptine, it goes 70 to 80%. But tumor shrinkage rate is vastly different. It's 50 to 60 in bromo and 80 to 90 in cab. 30 to 40% patients are going to respond with complete tumor shrinkage or complete tumor disappearance with CAB. Successful withdrawal is also possible. Successful withdrawal means that once the patient discontinues the drug, the tumor does not start regrowing. And the relapse rate it's comparatively lower than the cabergoline, than the bromocriptine. So if the medical management is so nice, apart from the other indications, what are going to be some more pitfalls if I put a patient for long-term dopamine agonist treatment? What are going to be some other potential problems if the tumor is huge, assuming? Any volunteers?
Visual can develop.
No. I'm giving you a hint. There is a huge tumor. Let me draw here.
Hydrocephalus?
No. We are assuming that the tumor is shrinking, right? This is the lesion. And this is sella. This was a huge lesion which completely filled out the sella. And then you started this patient on a dopamine agonist. And the tumor started shrinking. So what ended up happening was the sella was enlarged, right? And there was pressure effect on the sella. So if a tumor shrinks, what ends up happening? It's a very easy question. That's right. Who was this? That's right, CSF rhinorrhea, because due to consistent pressure in large tumors, the cellular floor might be eroded. There might be localized perforations. So what ends up happening is patient starts on cabergoline, the tumor shrinks, and lo and behold, we have a hole in the cellular floor through which CSF rhinorrhea can happen. There's another thing that happens, which is why a lot of surgeons do not
Empty
look
cellar.
forward. Sorry?
Empty cellar.
Yes, empty cellar. If a tumor completely disappears, then yes. And
Fibrosis of
Tumor
that.
becomes fibrotic.
Yeah.
okay, fibrosis. So what does the fibrosis do?
Difficult for the surgery.
That's right. So any patient who has been on dopamine agonist for a long-term therapy is not going to be a dream come true for the surgeon. Why? Because there's going to be a lot of fibrosis. There's going to be loss of the normal tissue plane, and the surgery is going to be difficult. Also, since the dopamine agonists, they induce fibrosis in the tumors, they also make tumors slightly radioresistant. So what ends up happening is, this is a nightmare scenario, by the way, that you have a patient with a huge lesion and you put them on cabergoline, and patient has been taking them for a long time. After a certain time, it stops responding and you plan surgery. So now the surgery is difficult because there's going to be stark fibrosis, there is going to be loss of normal arachnoidal or the normal tissue planes, and afterwards, assuming that the patient had some remnant in the cavernous sinus and you wanted to send them to radiotherapy, then this patient will also not respond to radiotherapy on the normal doses because it's going to be slightly radioresistant. Am I clear?
Yes, ma'am.
Okay, moving on. So indications we have already covered.
Relapse rate
If
is higher with hello?
yes,
Relapse rate is higher with bromocriptine, right?
relapse rate is higher with bromocriptine, remission rate is lower with bromocriptine. Bromocriptine is not the preferred drug in case of prolactinomas. We only use it if the cost is a significant issue, which often is. Honestly, it often is in the setups that we work in.
Okay,
So,
thank you.
Indications we have already discussed. If there is dopamine agonist resistance, you are giving them the maximum tolerable dose, which is 2 mg per week, right? And there is decreased response. The prolactin levels do not reduce, or the tumor volume does not reduce significantly. Then we label that case as dopamine agonist resistant. Then there is dopamine agonist intolerance, which I already discussed, that the patient cannot simply tolerate the medicine and they end up leaving it. Hence, we do not have any other option. If there is acute visual threat, which is when the patient has presented late to you, there's already hydrocephalus, or there is pituitary apoplexy, and the vision is threatened, then you need to proceed for surgery regardless of the functional status. CSF rhinorrhea is an indication. Cases in which the tumor has eroded the base and the tumor has shrunk down rapidly, these patients are going to need surgery. Cystic prolactinomas are notoriously poorly responsive to the medical treatment, and patient preference is also a choice. There are going to be certain patients who want to plan their family, and female patients who are planning pregnancy, they are usually not compliant with the medicine. They want a quick treatment. Apart from them, there will be patients who would not want the side effects that come with the medical management and the long term of the therapy. So patient preference is also a factor. So we have already discussed it. Chronic bromocriptine therapy, more for bromocriptine, but somewhat also true for cabergoline. They can make the tumor slightly more resistant due to fibrosis, and the surgery is increasingly difficult. The more time a patient was on the dopamine agonist therapy, the more difficult it is for the surgeon to take out the lesion. So what are some other functioning adenomas? We are going to breeze over them. Somatotroph, okay, it produces growth hormone, excess growth hormone, which stimulates the liver to produce IGF-1. What ends up happening is there are two different presentations, adults and children. Why? Because there is something called metaphyseal plates, which are the cartilaginous plates in the long bones of the children. And if they have fused, if the epiphysis has fused, then the height is not going to grow anymore. So that patient, even if, with the age group, even if they are a child, if the metaphysis fusion has happened, then they are going to present with acromegaly. If the fusion has not happened, if the growth plates are still there, then there is going to be gigantism. Why? Because the long bones can still grow. So what happens in acromegaly? The height does not grow, but all the soft tissues, which are called the acral tissues, all of them end up growing. And what do I mean by acral tissues? The tongue, the jaw, and the hands and the feet. So the patient is going to have frontal bossing, they will have macroglossia, they will have macronathia as well, enlarged jaw. There will be enlarged hands and feet, enlarged nose, and characteristically, they are going to tell you during the history taking that this has all happened recently. It was not, their physical features since birth. What are the systemic risks? So all the soft tissues end up growing. That includes, there is going to be cardiomyopathy, and when there is cardiomyopathy, there is going to be hypertension. Sleep apnea is going to be there due to macroglossia. What happens with the children? They have gigantism. There is a very famous person who was a motivational speaker, Tony Robbins. I don't know if either of you follows him, but he has a form of acromegaly. Change this. So this is a classic feature, a very common picture in the wards, in the OSCE stations. You can see that all the soft tissues are coarse. They are enlarged and they are coarse. This patient does not have as prominent macronathia, which is enlarged jaw. Let me see, I think I had another picture. Yes, if you see this patient's jaw, its mandible, her mandible has grown significantly. The nose has grown significantly. So these patients and the patients with Cushing's disease, the moon facies, they are diagnostic, they are spot diagnosis. They walk in the clinic and you automatically know that this is what is going on with them. This is gigantism. This patient got a pituitary tumor before their metaphyseal plates were fused, hence the abnormal height. So, what is the medical management going to be? In fact, it's not going to be the medical management. I think I have missed the slide. Oh, yes, I think I have missed a slide. Okay, just ignore this. We are going to come back to it. When we talk about corticotroph adenomas, it leads to Cushing's disease. Can somebody quickly go over Cushing's disease and Cushing's syndrome? I want to make sure if you're sleeping.
Diseases from the central nervous system means pituitary gland, or the syndrome is from the adrenal gland.
Okay, only adrenal glands?
Ectopic CTH secretion.
Anything apart from pituitary is Cushing's syndrome. Okay?
Okay.
So when the cause is pituitary, then it's Cushing's disease. What happens? We know when the cortisol is high, there are it's like a finally a medicine question. Centripetal obesity, there's buffalo hump, there's moon facies, there's very thin skin, which is prone to striations, easy bruising, osteoporosis is going to be there. Patient can have pathological fractures, there's going to be proximal myopathy. With regards to systemic effects, patient might have diabetes, there might be refractory hypertension, which is not responsive to any medicine. For the corticotroph adenomas, surgery is the first line treatment. This is a typical picture. You can see that there's buffalo hump, there's moon facies, there are multiple striations, weight gain, there's centripetal obesity, there's weight gain around the abdomen, and you can see that the skin looks slightly abnormal. So we have thyrotroph adenomas. They are rare. They're comparatively very rare. But when they happen, they cause secondary hypothyroidism. Patient is going to present with tachy, tremors, weight loss, heat intolerance, and both the TSH and the T3, T4 levels will be elevated. Elevated TSH is the primary abnormality. Elevated T3 and T4 are the response to the elevated TSH. Okay, surgery stays the first line treatment. Non-functioning adenomas, we are already assuming that for non-functioning adenomas, surgery still stays the first line treatment. How are they going to present? We discussed their presentation right in the beginning. Do you remember? Yes, mass effect and did somebody manage to read the headline of the next slide? No? Span hypopituitarism. Okay, and there's another thing which is very common. I think you're all forgetting. What ends up when a patient has pituitary adenoma, even if it's not functioning?
Vision.
Vision. Who was this with the headache? Yes, headache might be a problem, but vision is deteriorated. So mass effect, panhypopituitarism, and visual problems. What sort of visual problems we are going to see? So what ends up in happening with non-functioning adenomas? There's compressive loss. What do we mean by compressive loss? That, let me draw. This is a huge tumor. Okay. And this is the normal pituitary. Maybe it was growing from some portion of the pituitary, rest of the pituitary was normal, and it ended up getting compressed on the one side. So patient has hypopituitarism. What ends up happening is there's growth failure due to lack of growth hormone. There is hypogonadism due to lack of LH-FSH. There is going to be decreased metabolism due to lack of TSH. And there is going to be secondary adrenal insufficiency due to lack of ACTH. So this is the sequence where the hormones are typically lost. You can see, go look for adenoma. G is for growth hormone, L is for LH and FSH, and then we have TSH, then we have adenoma, which is ACTH. What is the rule of replacement in panhypopituitarism? Can somebody quickly mention?
Hydrocortisone injection.
Hydrocortisol, what?
Injection hydrocortisol we give.
Yes. So the rule of replacement in panhypopituitarism is always, always, always replace the cortisol before the other hormones, right? Especially before the thyroid hormones, even if thyroid is also decreased. Why? Because you can imagine cortisol as the fuel. If you imagine that the body is it's a car, it's a vehicle, then the cortisol is the fuel and the thyroid hormone is the accelerator. You cannot push the pedal, you cannot put your foot on the accelerator if there is no fuel. The car is going to shut down, right? So cortisol is the fuel. You have to replace the cortisol first, which we do by giving hydrocortisone before we replace any other hormones. If you do not do that, then you end up risking the shutting down of the car, which means that the patient is going to collapse because there is no cortisol reserve to meet the basic metabolic demand. Optic pathway compression. What ends up happening? There is a classic finding, we all know this, tunnel vision, bitemporal hemianopia, there's decreased visual acuity. I don't think I need to go into details, but I included just in case. Let me see. So what happens is, this is the optic chiasm, and below the optic chiasm, assume that there is this pituitary tumor. When it ends up growing, this is the chiasm, and this is the lesion. This lesion compresses the central portion of the optic chiasm if it is in the normal location. Okay, if it is in the normal location, then the retinal fibers, the nasal retinal fibers, they are compressed. When they are compressed, the sides are going to go away. Let me draw them. So this is how it's going to look by temporal hemianopia. Why? Because there are nasal retinal fibers here. The fibers cross. These are the nasal retinal fibers. They are crossing and they get compressed. When they get compressed, the nasal retinal fibers are carrying the temporal field. This is the temporal field, the one that is in white. So when they are compressed, the patient loses both temporal fields. Hence, we see bitemporal hemianopia and decreased visual acuity. Are we clear till this? I think the only new thing would probably have been the nasal retinal fibers. Even that should not have been new. We are clear till this, right?
Yes, ma'am.
What happens if the chiasm position is different? This is a better illustration, at least better than mine. You can clearly see what is going on here. Let me change the color. This is the normal chiasm. Normal chiasm is here. This here is the normal pituitary, assuming that we have a lesion that grows in this direction. There are going to be the nasal retinal fibers here, which are going to get compressed, and the patient is going to have bitemporal hemianopia. Okay? When you see, there are two other variations. There is a prefixed chiasm and there is a postfixed chiasm. What happens in the prefixed chiasm is optic nerves are slightly shorter. Optic tracts are going to be slightly longer. So when there is going to be a lesion, it's going to come in contact with optic tracts directly. So what is going to be the deficit? I'll give you a hint.
Homonymous
What is
hemianopia.
That's right, homonymous hemianopia. So it does not mean that if a patient has pituitary adenoma, they are definitely going to have bitemporal hemianopia. They can present with homonymous hemianopia if the chiasm is prefixed and if the tumor is coming in contact with optic tracts first. Okay. What happens in a postfixed chiasm? In a postfixed chiasm, optic nerve is longer than the normal length. So when this lesion grows, it ends up compressing optic nerve, often on a single side. So what is going to happen?
Single eye vision loss.
Decreased.
Yes, monocular blindness, and sometimes junctional scotoma as well. So what is more common in pituitary tumors, papilledema or optic atrophy? And if optic atrophy, what sort of optic atrophy?
Secondary optic atrophy.
Why secondary optic atrophy? What is secondary? Okay, can somebody, it's an interesting discussion. I think we are running out of time. Can somebody quickly go over what is primary and what is secondary optic atrophy?
Yes, doctor. Actually,
Okay.
primary optic atrophy when there is raised ICP, and secondary when there is pressure effect from outside, something like
No.
this kind of pituitary tumor.
No.
Primary is due to some neurological causes. Secondary is due to compression causing hydrocephalus.
Secondary optic atrophy is due to long-standing papilledema. It's very apparent from the name, right? Primary optic atrophy is when there's direct compression on the optic nerves and the optic nerve fibers end up getting damaged. So that is primary optic atrophy. Secondary optic atrophy is when there has been long-standing hydrocephalus causing long-standing raised intracranial pressure, which increases the pressure within the sheath of the optic nerve as well, and there's secondary atrophy. Their fundoscopic appearances are also vastly different. The primary optic, I am regretting that I did not include a picture. Primary optic atrophy has a chalky white appearance, whereas secondary atrophy has a dirty gray type a picture. If you have seen it in the patients on fundoscopy, you would know what I'm talking about. I did not think it was important, so I did not include the picture. But with pituitary adenomas, primary optic atrophy is more common. When does secondary optic atrophy happens or when does papilledema happens?
Due to
Anyone?
hydrocephalus.
Third ventricle
Yes.
get compressed because of third ventricle get compressed and hydrocephalus will cause secondary optic atrophy. Madam.
That's right. So if there has been a long-standing lesion with hydrocephalus when they have been presenting to you, so you might find papilledema, but papilledema is a very rare feature. It's not something which is common in the clinical presentation of the pituitary tumors. For pituitary tumors, primary optic atrophy is the norm. Papilledema is the rarity. So what ends up happening is when the chiasm is post-fixed, you're going to have primary optic atrophy. You might also have RAPD, which is relative afferent pupillary defect. You are going to shine light in the affected eye, and the pupil is going to dilate. I think we are not left with enough time, so let's move on. Okay, so this slide is basically whatever we have discussed in the previous slide. When there is prefixed chiasm, we have contralateral heminopia. When the chiasm in its normal position, there is bitemporal heminopia. When it is post-fixed, which is also uncommon, then we have monocular deficit with maybe junctional scotoma and RAPD. Primary optic atrophy is the usual feature. Papilledema is rare unless a huge tumor which is causing the raised ICP. Let's start with the interesting portion, radiology. Can somebody read the scan for me, please?
Dr. Kamal, can I try?
Yes, you can.
Okay, this is an MRI brain plane coronal section showing a lesion in the cellar and supracellular compartment compressing involving the both carotids, internal carotid arteries, and it is compressing the optic chiasm superiorly, pushing the optic chiasm superiorly, and there is no hydrocephalus seen. Thank you.
No.
Yes, you're
RB
right.
and Knosp. RB
Sorry.
and Knosp. Madam, she has not mentioned about Hardy's gland, Knosp. You have to mention in this Hardy, I think
You can
C,
mention it on her behalf.
Knosp,
That's okay.
Knosp 2, or Knosp B.
Sorry, Knosp what?
It's like, looks like Knosp
Mm-hmm.
2
Knosp 2. Why would you think Knosp 2?
is in the, madam, midline, I think. It's midline.
Okay.
Extending to the midline. It's midline, I think.
Okay. What do you think here? This is ICA, right? Let me
Yeah,
draw.
yes.
This is the lateral tangent line,
Yes, madam.
right? So this lesion is going beyond the lateral tangent line, right?
So it is going down 3B. Going down
Yes.
3B.
So it's going to be 3B. What do you think on this
Right
side?
side. Right side, left side also. Left side, it is 2,
Left.
3.
Yes, on the left side, it's not crossing the lateral tangent line.
Yes, ma'am.
Okay. So
It is 2.
whenever we are giving our input, we do not point out any other person. If you want to add something to their comment, we just tell that this is what we think that should be added.
तो हार्डी में क्या होगा, हार्डी क्या होगा इसमें मैडम? Like this will be Hardy, which one?
Hardy
we
grade
cannot we cannot completely comment on Hardy because we do not have the sagittal section. We don't know the status of the third ventricle and the recesses and how much of the compression is going on over there.
Hardy C होगा क्या? Not.
No,
we cannot
you cannot be sure. Always remember there is a trick with the radiology. If you have limited imaging, never go beyond what you're asked. You cannot safely comment on Hardy because this is only a coronal section. You do not have a sagittal section. You do not have an axial section either. So you cannot see where the third ventricle is, what is the status of the cisterns around it, whether there is compression going on or not. This is something that is going to land you in problems during rounds or during exam. If you have limited imaging, that's your best bet because you can comment on how much you're sure on. And for the rest, you can always say, since I have limited imaging, I do not know the status about the Hardy.
Yes, ma'am.
Okay. So what do you think on this?
Right. Right side is Knosp 1. Left side is 4.
Left side it is?
Encasing the entire ICA, it is grade 4, madam.
Okay. So this is where it gets interesting. This is a patient that we received in our ward a few weeks back, and you can see that the lesion. Now on this image, doctor, who was this speaking?
I'm Dr. Subham.
Okay, Dr. Subham, on this image, you can comment on the grading, yes, because you can see if
Prefrontal
yes,
extension, madam. It will be Hardy
yes.
4, Hardy D. Hardy
Okay.
D.
Okay, why do you think that?
Madam, because extension to the frontal, prefrontal extension is there, madam.
Okay, there's a very small mistake that you made,
Yes,
but that's acceptable. You could have told me that you cannot comment on the cavernous sinuses, so you do not know the status of the lateral extension, right?
yes, madam. But
When there is limited imaging, it's anybody who is appearing in the exam, because I know there are a lot of people. If you have limited imaging, be very limited with how much you can comment. Otherwise, I included this image because I could see certain vessels that were really interesting. I will share the coronal section of the same. Now you can see, can you see the cavernous sinuses here? No? No, right?
no.
You cannot see the cavernous sinuses here because this is a section at this level. You can see that this is basilar and these are the ACAs. They are going around the callosum, corpus callosum, and they're displaced here. So this section, the next section, is at this level. Let me see. You can see the basilar here. Which arteries are these? It's okay if somebody cannot comment definitively. These are ACAs. No. These are not ACAs. These are ACAs which have been displaced, completely. If you can see, there's a very small ACOM here. From this, you can see these are the A2. But it's completely okay if you cannot comment on the vasculature confidently, because obviously this is not an angiogram. But these are, and this here, there's a very small ACOM here. These are the A1s, and then they are going up. They are A2 and A3, and you can see that if you see this here, these vessels, they are getting compressed and displaced. So these are A2 and probably A3 as well, because they are following the contour of the corpus callosum. So always be very limited when you're talking about any radiology. Can somebody else volunteer for this image, please? Anyone? It's an interesting case. No? Okay. Okay. Dr. Subham, do you want to try?
Madam, you want to tell me about the Knosp classification or you want to
No.
tell?
Just comment on the imaging. I do not want you to comment on the classification.
Madam, there it's a sagittal section on the CT brain showing there is erosion on the floor of the cella.
Yes.
Ma'am, is it stage Hardy stage 4? Like there's perforations. I can see the sphenoid bone.
Okay. And what do you think about Knosp?
Ma'am, Knosp, I think
Right
there
side
is
is four.
right side is 3.
We can't
3B.
comment on the Knosp, the corner section.
You all of you took the bait again.
Madam, Dr. Subham, right side is 3B, left side is
Okay.
2.
You cannot say that. You do not have an
No.
MRI. You do not know the status of the cavernous sinuses because you
Someone
do
has
not have sufficient imaging.
Correct.
And the other thing is, even if you're going to comment, the lesion is very grossly involving. You can see that it's going paracellar, and the paracellar extension is pretty gross. So what are we assuming? We are assuming that the cavernous sinus has already been breached and the lesion is extending far beyond it, right?
Yes, ma'am.
So even if you're going to comment, you're going to say that it's 4.
Yes, ma'am. Great.
But the safest bet is when you have limited imaging, only comment on the things you see and try to avoid mentioning any grading. So yes, the interesting portion is there is no sella and there's something else going on here as well. What else is
Clival
missing? Yes,
clival.
there is clival erosion. The lesion has completely eroded the clivus. It has completely eroded the sella. There is significant extension in the sphenoid sinus, even in the ethmoid sinus. You can, there probably is nasal extension as well, but I would not comment on it. Let's move on to the next image.
What was the approach being done for this patient?
Oh, this is not my
Oh,
case.
sorry.
It doesn't
This is
look like
okay.
adenoma. It looks like some nasopharyngeal something.
No, it's not a nasopharyngeal lesion. This is a pituitary aggressive adenoma, which was reported. And I do not have the link in the presentation, but I can always leave the link on the group.
Yes.
This
Main
is a
important is
diagnosed pituitary adenoma.
repaired skull base repair will be very important in this case. Difficult also.
Yes, skull-base repair would have been really, really difficult. This is a nightmare case, and probably without gross total resection.
How the patient survived for so big lesions in coming to the.
Please let me complete, because if we ended up discussing like this, then it's going to take even longer than it already has. So there is another lesion, and what do you see here? The only reason I included this lesion was there's this hourglass shape, which was
Posterior
interesting to see. Yes.
Posterior pituitary, which is this is hyperintension T1 because of melanin pigment as a protein,
Yes.
which will be. Yes,
I was on image A, and what I wanted to mention here was that this is an hourglass lesion. And why is it hourglass? Because there is constriction at the diaphragma sella. So there is an infradiaphragma cellar portion, and then there is a supradiaphragma cellar portion. Hence, there is this snowman or the dumbbell-shaped tumor. Let me move on. We are running really, really late. So aggressive adenoma versus pituitary carcinoma. Oftentimes we end up leaving them, so I wanted to include these. Pituitary adenomas, they have very typical features. I'm not going to discuss them, but aggressive adenomas, they are the ones with extensive invasion of cavernous sinus of the bone, which is sella, the clivus. There can be sphenoid involvement as well. How do we classify that these are aggressive? Their Chi67 is going to be more than 3%. Their HPF is going to be more than 2. And their P53 expression is strongly positive. Their response to the treatment, the medical treatment, is very poor. And even if you end up doing surgery, there's frequent recurrence. Even if you end up doing surgery and you end up giving them radiation. But these do not have metastasis by definition. If these lesions have metastasis, then it upgrades to pituitary carcinoma. With carcinomas, you typically have very high Chi67, more than 10% often, high mitotic count, and P53 is strongly positive. Their response to surgery and radiation and the medical management is very, very poor. But you need meds for diagnosing them as carcinoma instead of aggressive adenoma. You either need leptomeningeal seedling in the CSF sample, or you need evidence for systemic meds. Interestingly, there is some role of temozolomide, and it's very similar to the temozolomide role in the gliomas. For both aggressive adenomas and carcinomas that have failed surgery and radiotherapy, you can give them TMZ, but the response will still be linked to the MGMT. Okay, investigations. I think we will take over from here in tomorrow's session. The investigations, pituitary apoplexy, and then maybe we will end with the endonasal transdermal approach. So thank you so much, everyone. I'm sorry for wrapping up suddenly. I have just looked at the time and it's really late. So please leave me questions on the group, any feedback, any questions. All are welcome. All the exam candidates, please take time out to remember the normal levels of prolactin, the ranges, the relapse and the remission rate with the dopamine agonist, and the surgical indications. Please go over them, and I will share this presentation in the drive, inshallah. Thank you so much, everyone. Please leave me questions and feedback on the group. I cannot take them live today.